All right, so we are now recording. Again, I would like to say welcome to everyone. I see we have folks coming from Pennsylvania, Richmond, Virginia, Arizona, Kansas, a lot of Minnesota. We're so excited for all of you to join us. So this is Johnanna Gans. I am the lead rural technical assistant for our rural program. So I work here for the Sexual Violence Justice Institute at the Minnesota Coalition Against Sexual Assault, and I am especially excited today because we are going to have this webinar talking with our very own in-house expert, Jude Foster, on medical forensic response in rural communities. So in particular, we're focusing on medical forensic response in rural communities because this is an issue that just comes up in my technical assistance from all over the U.S. and in the U.S. territories consistently. So really excited to welcome Jude. And so with that, let us get started. Of course, above all things, we want to say thank you to OVW. This particular webinar is supported by our grant through OVW. Without them and their funding, we couldn't provide the technical assistance that we do for you folks. So big shout out. Thanks, OVW. Okay. So just a little quick information for you folks about the Minnesota Coalition Against Sexual Assault and the Sexual Violence Justice Institute. For those of you who are newer to our webinars, for those of you who are not newer to our webinars and are very well versed in who we are, go ahead and think about your life choices or check your email for a minute. So a little bit about the Minnesota Coalition. We are, of course, a statewide coalition, and we work in a variety of areas that you see on your screen. So we work in public policy, we do quite a bit of work in prevention, and we spend a lot of our time doing trainings and support for systems professionals all across our great state of Minnesota. We do a lot of work around supporting advocates in addition to law enforcement, prosecutors, corrections, and allied systems professionals. Within the Minnesota Coalition, we have the Sexual Violence Justice Institute. So we are a small but mighty bunch. We've been around for quite a while, starting early 2000s. We are a national technical assistance provider. That's how we are bringing you this information here today. So we work pretty extensively with the Office of Violence Against Women. Again, one more thank you to them. And we provide technical assistance on a range of issues revolving around response to sexual violence. And specifically, we really look at and provide support around collaborative processes. So any sort of teaming or team-like work that is looking at how we can better improve sexual violence responses in our communities. So some that might be protocol development. For those of you who are familiar with protocol, you've probably just groaned a little bit in your heart. It does amazing work, but can sometimes be really challenging. And so we're here to help with that. And we also do quite a bit of work, especially in the state of Minnesota. And Jude has been an integral part of doing quite a bit of this, looking at forensic exam access and ensuring that all communities have access to compassionate and competent care providers. So without any further ado, that's us in a nutshell. I'm going to hand it over to Jude after just two quick announcements about logistics. So we have a chat function, which a lot of you have found, which I'm very excited about. Again, welcome everyone. You can at any time during the webinar chat in your questions or your comments. In particular, if it is a longer discussion question, we will absolutely save that for the end. So that way Jude can answer questions together, and that way if your question's already answered in her content, we won't have interrupted some of that flow. If you have anything urgent or like you're like, oh wow, that's really confusing, I'm not sure what this means, that's absolutely an opportunity. Go ahead and send in your questions. Those were my two, I combined them into two. So there's a chat function, go ahead and use it. And second, we're gonna hold questions until the end. So with that, drum roll, I'm going to now hand it over to Jude Foster.
Hello, everybody. Thanks, Johnanna. So my name is Jude Foster, and I'm the Statewide Medical Forensic Policy Program Coordinator with the Sexual Violence Justice Institute and the Minnesota Coalition Against Sexual Assault. One of the first things that I tell people when I introduce myself is that I am not a nurse. I just celebrated my 25th year of being an advocate, and I have provided services in rural, suburban, and urban communities, and this is my second time working for MnCASA. I was here from 1999 to 2004, and I just returned in 2016, and I'm really excited to be back. So we wanted to ask a question today. We want to know, what is the most challenging issue your community faces with medical forensic compliance? Or what is something you would like to learn about medical forensic compliance? Go ahead and answer that in your chat.
So we're going to be quiet for just a minute while y'all have a chance to go ahead and type in your answers. So if it gets real quiet, don't worry, we are still definitely here. Okay, so it looks like we've got our first couple of chats in. How to safety plan, we see sustainability of program. Ooh, they're all coming in. This is great. Safety plan around the possibility of SAM showing up on benefits explanations. Looking for a basic overview, wanting new information, particularly looking at rural area and closest hospital being 30 miles away. Staffing, there's no SANE program and nurses are uncomfortable handling evidence. We're worried about safety while on the job. We see hospitals not calling a SANE because they don't want to pay overtime. Challenges, lack of coverage, ability, or distance and access to the forensic nurse examiner. Rural communities, of course, no SANE nurse. ER not used to doing the kits. For advocates, that's frustrating. Really wanting to look at compassion towards survivors. Not having a certified SANE nurse program. I'm just going to give it one more second for anyone else who wants to chat in what they want to learn or what they find to be a little bit frustrating and are hoping for information around. Ooh, what it looks like when a minor may choose not to report after an exam, but the parent wants it reported. Can the parent force it? We can save that one especially for the end for our question session. Law enforcement or hospital is not contacting, getting HIV medication protocol in place. SANE nurse doesn't take photos when doing the examining. One more second here while people finish chatting in. Looks like a pretty wide variety of things going on for folks. No SANE nurse, absolutely. So, yep, you can, a doctor told me a 13-year-old cannot consent to the forensic portion, looking to see if that's true. Hospital staff recognizing the need for rooms with pelvic exam tables, absolutely. There's a whole bunch of stuff going on. So you can go ahead and keep chatting stuff in. We'll keep track of any major questions and we'll come back to them there at the end. Thank you so much for sharing it, everyone.
All right. It's not.
Oh, I got it.
Okay, thanks, Janina. All right, there we go. Okay, so the Minnesota Coalition Against Sexual Assault has been working on medical forensic compliance for about 8 years now, and it's kind of morphed from project to project. What we've learned over the last 8 years, and I think this is true in Minnesota, but I think this is true nationally in other states that we talk to, is that there is a need for increased coordination. So we hear about things that are going really, really well in some parts of the state, and then we hear about things not going so well in other parts of the state. We know that victims receive vastly inconsistent medical forensic services. So we know that victim survivors that are going for evidentiary exams in the metro area, so say like Minneapolis and St. Paul, where there are SANE programs, is very, very, very different than somebody in rural Minnesota where maybe there isn't a SANE program, and you have untrained medical staff. We know that that medical forensic approach, when it's inconsistent, can have a very negative impact on victim survivors. Many times, victim survivors, that is their first contact with the criminal justice system, and we know that if that is a negative experience, that victim survivors may disengage right off the bat after that exam. So people ask me a lot, what exactly is medical forensic compliance? With the Violence Against Women Act, or VAWA, it has requirements around, it has forensic compliance mandates for systems professionals, including medical folks, to follow, and that can affect federal funding mostly through the STOP grant money, so that's the Services, Training, Officers, and Prosecutors money. And if your state is not in compliance forensically, that can jeopardize your funding stream. So that is something that I like to remind systems professionals, that it's not just ethically the right thing to do, but it can also jeopardize your grant money coming into your state. So the two primary requirements that every state, territory, or tribal community must comply with in order to keep receiving their grant money is, the first one is that victims must have access to medical forensic exams without participating in the criminal justice system or cooperating with law enforcement. So victim survivors can get an evidentiary exam, and they do not have to report to law enforcement. The second piece is that victim survivors are not responsible for the cost of their medical forensic exams. So when we start talking about compliance, yes, we're talking about systems needing to conform to official requirements and the privilege of receiving public grant funds, but it's really about cooperation. And I think when we talk about medical forensic compliance, it kind of gets real focused on the medical systems. But medical forensic compliance is all of our responsibilities, and we're all participating. So that means law enforcement needs to be cooperating, prosecution does, advocacy does, and it really comes down to best practices. So really sharing those best practices, supporting people, and abiding by best practices, those kinds of things. And why is this so important? We know that removing the burden of cost for the victim decreases barriers to exams. So we know that the vast majority of victim survivors are not receiving medical attention after that they've been sexually assaulted. And in the early days of my advocacy here in Minnesota, it was a requirement to get your evidentiary exam paid for. You had to report to law enforcement. And there's a lot of reasons why victim survivors do not want to report to law enforcement. And some of those reasons might come down to safety for the victim survivor. So really there's two philosophies when we're talking about these things. So there's the justice philosophy. We know that victim survivors, when they're getting an evidentiary exam, they're essentially dipping their toe in the water to see how they feel about systems, how they're feeling about reporting. We know that if a victim survivor enters a medical facility and they have a positive experience with a medical professional, that might be a sexual assault nurse examiner or a SANE. It also might be somebody just working in the emergency department that's doing the exam. If they have a good experience with an advocate that's responding to the hospital, we know that the chances of reporting go up significantly. It also increases victim access to the criminal justice system and it improves case outcomes. So when prosecutors and law enforcement are really going through that investigation and making the decision about charging cases out, I think it's pretty important to have had a medical exam. It's not impossible to get your case charged out without one, but it significantly can increase that possibility. And I think the other philosophy is healthcare, which is where the advocate in me leans more towards. But that increases victim access to health professionals. Most victim survivors that have been sexually assaulted that are entering medical facilities have not experienced substantial injuries. That does happen, but it doesn't happen as often as I think a lot of people think. But I cannot tell you the power that medical professionals have when they make eye contact with a victim survivor and say, you are going to be okay. As an advocate, I don't have that power, law enforcement doesn't have that power, but a medical professional does. And we know that by getting an evidentiary exam, it improves the physical and psychological outcomes for that victim survivor as well. And when we talk about medical forensic compliance, I like to remind folks that when we're taking a victim-centered approach, that's not just the job of an advocate. We all should be looking at these things. So considering the victim first, I'm sure many of you have seen this list before, that we're listening to victim survivors, that we're really promoting victim self-agency. I always remind folks, patients, if you're a nurse, if you're an advocate or law enforcement, for example, victim survivors, they are their own best experts. We are not. So really letting victim survivors make those decisions, really coordinating and collaborating in the victim's best interest, ensuring victim safety. As I mentioned before, sometimes victim survivors are not reporting to law enforcement for some really concrete safety concerns, depending on who the perpetrator is. We want to seek just solutions for all, and we really want to hold ourselves and others accountable. So some of the things that you all said when we asked you to type in the chat, what some challenges that you're seeing, some of those I'm going to address right now in my slides, and when we're done, I'll address more of them. But these are the challenges that I see in my job. And I jokingly tell John Anna all the time that I have never loved and hated a job simultaneously as hard as I do. I love my job. But there are many days where I feel like I'm just beating my head against the wall. So these are kind of the most common things that I deal with the technical assistance that I provide and training that I provide. The first thing is there's not a definition of what goes into a sexual assault kit. I know that varies state by state. Here in Minnesota, in our last legislative session, we tried to address some of this, but there's a lot of disagreement about what is a sexual assault kit. Exam access and quality. So many of you chatted in, the nearest hospital is 30 minutes away or 30 miles away, or there isn't a SANE program. And I will be addressing that. I love SANE nurses. I work very closely with the SANE nurse by the name of Wendell Walther. She is our SANE consultant. I've been working with SANE nurses for many, many years. But the fact of the matter is that we just can't sustain SANE programs in every single community. So I will be talking about some alternatives to that. Sexual assault kit storage is a huge issue. And again, in Minnesota, it's a huge issue in some parts of the state. In other parts of the state, it's not such a big issue, and people are working through it just fine. We're going to talk a little bit about sexual assault kit testing. And then probably one of the most frustrating parts of my job is the statewide and community coordination piece. So what is in a sexual assault kit? As I mentioned before, there are disagreements about what constitutes evidence collection and treatment. So for example, if we have somebody who is doing an evidentiary exam and they are doing that exam in a victim-centered manner, they're communicating with the victim survivor, you can consent to as much or as little to this exam as you want. So we could start an exam and start swabbing a victim, and a victim can say, no, don't do that anymore. Some victim survivors don't want any swabs taken for DNA collection, but they will give that medical professional their history, the history of the event. So we have a lot of disagreements, and this comes into probably my number one most frustrating part of my job, which is billing. When bills aren't getting paid, this is oftentimes what it comes down to, is that in Minnesota we have a county by county payer system, and sometimes the county payer doesn't want to pay. So we have questions about, is the sexual assault kit, is it just swabs for DNA collection? Is the patient history part of the sexual assault kit? And then what about prophylaxis? So prophylaxis for sexually transmitted infections and for pregnancy. And I did see somebody mentioned something about the HIV prophylaxis, which is very expensive. And how are all of these sexual assault kits billed, as I mentioned before? So there are hospitals that say we shouldn't have to pay for the prophylaxis if we don't think that that's part of the kit, or now a medical professional came in and took the patient history and that took an hour, but now that we don't have swabs, can we bill for this? And there's just a lot of questions about this. So as I mentioned before, we really tried to address this in our legislation. Some good things came out of our legislation this past year, but this was something that we just couldn't hammer out. And it's something that really needs to be addressed. So I'd be curious if people are willing to share if that's an issue in their state. Okay, exam access. Victim survivors should have the exam performed at the facility to which they present. For those of you who know me that are in this call, you know that I do not use the word should. I think the word should is an extremely judgmental word, but here I'm going to go ahead and use it. I'm going to break the rule. I'm going to say should. We hear horror stories about victim survivors that are presenting at a hospital where maybe they're very, very insecure about doing the exam. Obviously, there's no SANE around. Doctors don't want to perform the exam, and that could be because, they're terrified because they're collecting evidence, they're worried about testifying. Also in rural areas, if a sexual assault victim survivor presents, that can tie up a nurse for 4 hours and, looking at resources and those kinds of things. So anyway, we hear stories about victim survivors being turned away from hospitals. All over the country, we've heard that. So that's something that we're very concerned about. Competent and compassionate medical forensic response looks differently in every community. So one of the things that we do in my program is we do 40-hour SANE trainings. We have another one coming up at the end of October, which we're pretty excited about. But as I mentioned before, not all communities can really sustain a SANE program. First of all, they're very, very expensive to run. But also, for SANE nurses to keep up their competency, So if you can go through the best SANE training in the world, but if you're only seeing 2 or 3 cases a year, how do you keep your competency up? So what we have been doing with our SANE consultant, Linda Welser, is we've been going into communities that can't sustain a SANE program. We've been doing 8-hour medical forensic training. So folks, anybody in an emergency department can do the exam. And so really, really training ED staff members, this is how you can do an exam. It's, again, we're trying to basically cram a 40-hour training into 8 hours. But there's been some really nice consequences for those trainings. So for example, medical folks that dipped their toe in the water and went through an 8-hour medical forensic training are now much more interested in going through a 40-hour SANE training. So that's been really, really nice. But I think victim survivors at the bare minimum have the right to get a competent and compassionate exam wherever they present. And they should not be turned away and pushed off onto other hospitals. And it's, again, talking about rural communities, if you're being asked to go to another hospital that is an hour away and you have 20 bucks in your checking account and a quarter of a tank of gas, that is a huge barrier for victim survivors. Again, medical forensic exams can be performed by professionals that are specially trained in sexual assault evidence collection. I have not heard about law enforcement or prosecution or the myth that they need to authorize exams in Minnesota, but when I talk to other states, I have heard that there are states where hospitals think that they need to get the evidentiary exam okayed by either law enforcement and prosecution, and that is simply not true, and that's another huge barrier.
So Jude, in our chat line, just so everyone else can hear, because not all the chats go out, we're seeing that for your question, we're seeing a lot of comments about payments being a consistent issue for folks, especially when there's county lines being involved.
Yes.
So if one's taken, a report is taken, but the assault occurred somewhere else, confusion around who is required to pay, as well as issues around whether DNA collection has been involved or not. And when DNA collection is not involved, the question of whether they should pay for that. So echoing a lot of what you brought up.
And yeah, I'm thinking about a case that I just had recently, although I've heard this scenario many times, where maybe a victim survivor had been drinking and had memory loss. I'm thinking about one case in particular where there were 2 bars in one town. The county line ran through the town. There was one bar in one county, the other bar was in the other county. The victim survivor was not sure which bar she had been assaulted in. And it's things like that. Yes, so that is a huge piece of billing is probably the #1 technical assistance service that I provide. And I'm sure all of my coworkers are tired of me talking about billing because that's all I talk about at work. Okay, kit testing is another big issue. So we've all heard about this kit backlog, and there are some communities across the country that actually do have a sexual assault kit backlog. We know communities like Detroit, Cleveland, Houston, we've been hearing about those things where there's actually a backlog at their crime lab. Here in Minnesota, the Minnesota Bureau of Criminal Apprehension did an audit, and they did find a backlog of kits. I would argue that they were not, it wasn't a backlog. So we didn't have a whole bunch of kits that were piling up at the Minnesota Bureau of Criminal Apprehension. What we had is we had law enforcement agencies that were not submitting kits. And that is another thing that our legislation did address that went through this past year. So, well, I'll get back to that in a minute. When you look at best practices, so it could be the International Association of Forensic Nurses, the National Institute of Justice, and Violence Against Women International, they're all coming in with the same recommendation that only reported sexual assault kits should be tested. So some of you might have heard about the national campaign to test all kits. That really takes the victim autonomy away. So we really only want reported, or here in Minnesota we call them unrestricted kits. Those are the only kits that we want to see tested. All reported sexual assault kits should be submitted to crime labs as soon as possible. I know that sounds like a no-brainer, but going back to what we're seeing in Minnesota is we have law enforcement agencies that were making decisions that we think they should have consulted with prosecution on about which kits are getting submitted and which aren't. So a classic example is when people talk about consent defense cases. You know, we hear, well, we already know who did it, so why would we test the kit? And the thing is that when we do collect DNA evidence from victim survivors, it really corroborates the victim survivor's story. So if the victim survivor is telling you, I was vaginally sexually assaulted, I was also anally sexually assaulted, and the perpetrator is saying, no, I only vaginally assaulted this victim, well, we have the DNA evidence that can support the victim survivor's account of what happened. So that's another reason why we really want all of those unrestricted or reported kits sent in. And in Minnesota, what we just passed is that law enforcement, if they're not going to send a kit into the crime lab, they must have a conversation with prosecution, and prosecution is going to go ahead and sign off on that. Yes, Joanna.
There's a question that seems a little more pressing.
Okay.
How do you define a reported sexual assault kit for testing?
Really good question. So in some communities, there are alternative reporting options. So in some communities, they call it anonymous reporting. In some communities, they call it Jane Doe reporting. So that is when a victim survivor can go in, they can get the evidence collected, and then so it's preserved. They've followed the chain of evidence in custody, but the victim does not want to report at that time. So sometimes an ICR number is generated. Like I said, nationally, this is happening, so every community does it a little bit differently. But it's so the evidence can be preserved, and then the victim has the option of converting that case from an unreported or restricted kit to a reported kit. So going back and saying, I would like to report this. So what we're saying are victim survivors that go in, get the evidentiary exam, and report to law enforcement at that time, that is what we are defining as a reported kit or an unrestricted kit. I hope that answered your question. Okay, kit storage. Here's another issue that can get really volatile, excuse me, not viable, pretty quickly. So best practices, again, when I say best practices, I'm referring to the National Institute of Justice and Violence Against Women International and the International Association of Forensic Nurses. Best practices are saying restricted sexual assault kits should be stored with law enforcement. This can cause a lot of friction in communities because some law enforcement says, going back to those restricted or unreported kits, why would we store these kits if it isn't evidence. I've also talked to law enforcement that does house those restricted and unreported kits that say, well, it's potential evidence, so that's why we hold it. Hospitals are very concerned about holding kits. So again, we're talking about those unreported kits because, first of all, a lot of the refrigeration, especially in rural hospitals, we're not talking about a huge professional freezer or refrigerator. We're talking about like a fridge that you would put in your dorm room. So we get very concerned about temperature control. We get concerned about refrigerators getting unplugged. We also, I really hope you're not eating your lunch right now, but we have even heard stories about people putting their lunch in the same refrigerator that kits are in. We get worried about chain of evidence and chain of custody, who has access to that fridge. So, and also hospitals don't have the space. They just don't have the space to store them. So that has become a huge issue. In the National Institute of Justice came out with a report a few months ago that really talked about holding sexual assault kits for at least the statute of limitations. I know in some states there is no statute of limitations on sexual assault, so that kind of made some people cringe that have concerns about the kit storage. But that's something that we are striving for here in Minnesota. We also have questions about how the sexual assault kits are being tracked. I've talked to some states that have outstanding tracking systems, which is really helpful because then victim survivors can ask, where is my kit? Did it make it to the lab? Those kinds of questions. And it's really accessible and easy to answer those questions for victim survivors. Here in Minnesota, we don't have a tracking system, and we're working on that diligently right now with our crime lab. We also want victim survivors notified when their sexual assault kit is destroyed. So sometimes folks are like, hey, we'll hold your kit for X number of years or X number of months. And then if you're not going to report it, we're going to have to destroy it. We really want victim survivors notified of that. And then going back to kind of what I was talking about before with climate control and security. So I know that there are, I always like to talk about my friends in Wisconsin, who I'm so impressed with. They didn't build a multi-million-dollar structure. They built a pole barn that has security, that has climate control, and they have statewide kit storage. I love it. It doesn't have to be so complicated. Yes, Joanna?
There's a question specifically about how long does Minnesota typically keep the sexual assault kit? And does that vary by county?
Yes, that varies vastly by county. It's county by county by county. And there is no typical. There's no, I can't even give you a range because for some folks it's 3 months, for some folks it's 7 years, for some folks it's forever. Great question. So when we talk about statewide and community coordination, so if you're struggling with these issues in your state, the first thing I just want to tell you is that you can't do this alone. You can't. Everybody is responsible for compliance. So kind of what I was saying about before, this is not just the medical profession's responsibility. It's not advocacy's responsibility. It's all of our responsibilities. Because I work for the Sexual Violence Justice Institute, I'm going to go ahead and plug collaborative multidisciplinary teams. I think that is a great place where you can get everybody at the table to be talking about these things. And if you don't have a multidisciplinary team in your community, you can go ahead and just convene folks on a limited basis to be discussing these issues. I give technical assistance to 2 teams here in SART teams in Minnesota. And I will tell you, these issues come up consistently on teams, and it comes up several times a year. So I really enjoy those conversations, and it just really gives communities the space to be able to hold those conversations. When we talk about multidisciplinary teams, you can have many partners because we know different communities look really differently, but we really, especially when you're talking about medical forensic compliance, you need to have law enforcement, medical, advocacy, and prosecution at the table. We're also really talking a lot about best practices, encouraging trauma-informed investigations. So really trying to get that consistent across the state. Some people are using studies, some people are using trauma-informed victim interviewing. We just really want folks to be exploring that. And again, protocols are critical because this is where you can really, again, have that transparency in your community, have the hard conversations, and then you can write it down so you're holding yourself and you're holding your community partners accountable for medical forensic compliance. And, you know, I was recently working with a community where it got very volatile around kit storage, and it was the hospital saying, no, we can't hold these kits, and law enforcement saying, we don't want to hold these kits because it's not evidence. And I finally asked, I said, well, how many kits are we talking about? Are we talking about, 150? Are we talking about 50? What are we talking about? And they looked at me and they said 10. And that blew my mind. I mean, professional relationships were being destroyed over 10 kits. And that just kind of blew my mind. So.
Was there a resolution to that case, Jude?
There sure was, John Anna. We compromised, and the hospital compromised and said, fine, we can hold them for 6 months. So that's where we're at right now, and we're hoping that, like I said, working with our Minnesota Bureau of Criminal Apprehension on some kit storage issues, I would love to have a centralized location like Wisconsin has. So we're going to get into some questions right now, John Anna?
Yes, absolutely. So we wanted to make sure with this webinar, because medical forensic compliance is a really big and complex topic, we wanted to make sure that there was a lot of time for questions. So we wanted to focus more on the overview, and so if you still feel like your question has not been answered, now's your time. Please chat us in the questions. Jude is awesome and knows lots of things, and anything she doesn't know, she usually knows who to ask to find the answer. So go ahead, chat in your questions, and for now, we'll start with some of the questions from earlier that didn't quite get answered yet. So with that, Jude, can a 13-year-old consent to a forensic exam? And in addition, can a parent force post-exam reporting for minors? Okay. I hate answering questions with this answer, it depends. It's really state by state. In Minnesota, we have some very strong legislation around minor consent. So yes, in Minnesota, a 13-year-old can consent to having that evidentiary exam. What was the second part of that question? Can a parent force post-exam reporting for a minor? That gets tricky. That gets very, very tricky. And I have seen SANE programs kind of stick their legal team together to try to protect that minor's confidentiality. It's not helpful, I think. I really think in those situations, it's really helpful to work with advocacy. I know when I was an advocate who responded a lot to medical forensic exams,
a lot of times the nurse and I would kind of play good cop, bad cop. I would kind of work and negotiate with the parent. I think when youth feel like they have that autonomy and they have that confidentiality, they're going to be much more transparent. They're not going to be afraid of consequences, those kinds of things. So I think it's in the minor's best interest that we respect their confidentiality. Also from an ethical standpoint, it's not good when you're doing that. The other thing that I just want to bring up, and I know this wasn't specifically in that question, is that no one should ever be forced into having an evidentiary exam. And I know I've had that conversation with parents where parents, I'll give you a good example, maybe a 14-year-old is quote unquote in love with their 45-year-old boyfriend. Am I a fan of that? No, I'm not. But mom brings daughter into the emergency department and 14-year-old is saying, but I love him. And mom says, I don't care if you have to drug her and tie her down. I want an evidentiary exam so we can get that DNA evidence. That should just never be happening. And I know SANE nurses will say ethically we can't do that. But I know that that has been a problem with attempts of that in many, many communities.
A related question, and we've got a couple more coming in. What about the role of guardians when the victim survivor is a person with a disability? Have you encountered challenges on this front? And if so, what has been best practice response? I will say that I chatted out, there's a really great technical assistance provider who focuses as one of their main projects on supporting folks with intellectual and developmental disabilities. It's the VERA Institute of Justice. So in addition to whatever Jude is going to say, definitely check out VERA. I've gotten technical assistance from them on questions in serving survivors with disabilities. I've also been one of their sub-grantees in a different job. So I've worked quite a bit with VERA. So Jude, any experience with that?
Yeah, it's getting consent for the exam from the guardian?
Potentially, which is what is the role of guardian when the person has a disability?
Well, and it depends again on there's different levels of guardianship. So is this person making all of their medical choices? I know that we have concerns. What if the perpetrator is the guardian? It can really fluctuate. I think that's when you have concerns about that. That's a really good time to call the hospital social worker. And in most states, you know, you have anywhere from 24 to 72 hours to report. So if we're talking about a rural hospital and say it's 3 o'clock in the morning and the social worker clearly isn't there, that's something that can wait till the next day. That's also when I call adult protection and I have a hypothetical. I always run hypotheticals by them and ask them because they're the best experts. Yeah.
Thanks, Jude. For those of you who just sent in the questions, so a couple of you did, I just sent the link in the chat box to the VERA project, Uniting to End Violence Against People with Disabilities. You can absolutely go through their resources, their trainings. They have a bunch of, they have their links for technical assistance if you want to give them a call directly, that they can give you really specified information for your state and area. So we have a couple of other questions. We actually got quite a few questions to work through, which thankfully we saved plenty of time. And that is an exciting part of our design. Yay for us. So, Jude, do we test our sexual assault kit backlog on the assumption that they consented to testing when they consented to the SAC? Is that how, can we shorten it to SAC? Or
yes, we sure can.
Okay.
I'm just trying to get out of alphabet soup because sometimes people don't know what I'm talking about. So the question is, can we test the backlog? Okay, the problem with that, and are we talking about not a real backlog, but a backlog at a crime lab, or are we talking about those accumulation of unsubmitted kits by law enforcement?
Let's address both.
Okay, well, I think that you know, here in Minnesota, again, there were a couple communities that were identified as having very high accumulation of unsubmitted kits. And the crime lab said, well, for Pete's sake, please don't send us, you know, 8 million kits at once. So they made arrangements with those communities. You know, you can send us 10 kits a month kind of thing. Because remember, I mean, the crime labs, and especially if there's a accumulation of unsubmitted kits, there's still cases that are criminal cases that are coming in that need DNA testing, and it's not just sexual assault. You know, it can be homicide, it can be other crimes. So I think that is something that communities really need to have a conversation with their crime lab about. The other question with the unsubmitted or the actual backlog, yeah, those are slowly being ticked away, and I would encourage folks to really explore what Detroit did, what Cleveland did, what Houston did. So those backlogs are becoming much smaller.
Thanks, Jude.
Mm-hmm.
Question. So this is a question from the audience.
Okay.
So if a victim survivor goes to have an exam and asks not to have DNA collected, is the exam still covered? Can advocates explain to hospital and medical facilities that the exam is still paid for?
That is a really good question. That kind of goes back to that slide that I had earlier about what is in a sexual assault kit. I'm going to go ahead and argue, yes, it is part of the sexual assault kit. It's part of the exam. And yes, victim survivors, again, get to consent or decline any part of the examination. So you could collect swabs and not get a history. That's totally up to the victim survivor. Yeah.
So question from the audience, can you speak more to SANE sustainability in general, especially in regards to funding and maintenance of skill? That's the question, but then they add some context. In Arizona, we have several counties without a SANE program, and victims are transported up to 4 hours away for an exam. So funding to pay for the SANEs and low reporting rates continue to be a big challenge for their rural areas.
Yeah, I've spent some time talking to Arizona. We're in the same boat on quite a few issues. Yeah, I think, well, one thing I will say is that I'm watching a couple communities pretty closely right here in Minnesota where they started a SANE program and maybe there were, 10 to 15 cases, and then bam, a SANE program is established, and then, they're slowly going up. So that SANE program that I just referenced, I think they're up to 30 or 40 cases a year. When a SANE program becomes established, the community finds out about it. And there's lots of different ways that you can do that. You can work with the media, you can educate the community through a lot of different venues. But so we do know that cases reporting and demand for SANE exams are only going to go up if you have a SANE program. But that sustainability piece is real. I'm thinking about a SANE program where they have very, very little funding, so they can't pay their nurses call pay. So it's basically like a calling tree. And it's working, but those nurses deserve to, at the bare minimum, get call pay because they have a very, very difficult job, and that's taking, and these are casual positions most of the time. So most SANE nurses that you will meet have a day job somewhere else, and this is like a second job, and that's taking time away from your family, that's taking time away from maybe other professional endeavors. So that can be very, very expensive, just the call pay. And then again, that sustainability of rural hospitals. For the first time in my career, I am advocating for rural hospitals. I've been doing that a lot in the last 2 years, and it's usually a billing issue. So things get very, very tight. Rural hospitals are really looking at programs. They're looking at where they can cut. So kind of selling it to a rural hospital, hey, let's start a SANE program, that's going to be very, very difficult. And then as far as the competency goes, again, if you're doing 1 or 2 cases a year, can you really keep your competency up? One of the things that we're doing here is we have a SANE shadowing program, which is currently not up and operational, but actually this week I'm working on a grant so we can bring that SANE shadowing program back. But what it does is in the metro, there are 3 SANE programs that cover like the 7-county metro around Minneapolis and St. Paul. And what we can do is pay for nurses their mileage to come down for the weekend. We can put them up in a hotel and they can shadow a nurse. Because there are some, when I was an advocate in Hennepin County, where Minneapolis was, we were averaging 7 exams in a weekend. So giving nurses that opportunity. I also worry about going back to SANE nurses. This isn't necessarily true of medical professionals that are doing exams in emergency departments, for example. But I worry about peer review. I worry about SANE's getting the support. And again, that's probably the advocate in me, because in advocacy, we take supervision and we take support of advocates so seriously. And I get really worried about SANE nurses just because of vicarious trauma and those kinds of things.
Someone had chatted in much earlier in our chat, particularly around the issue of competency and staying on top of your skills. For competency at the Central Minnesota Sexual Assault Center, they've used simulation labs at facilities to maintain competency. So that's one suggestion you folks out there across the landscape might want to consider, is figuring out how you can work together to really develop that simulation lab to be able to keep up skills for those nurses that you do have that are trained.
That's an outstanding idea.
Love that.
Mm-hmm.
So a question I actually have for you based on everything that you've said, so this is not audience questions, but please keep chatting in your questions. We love them. Jude loves them. I can't see her face, but she's an extrovert, so she loves these. What does a competent and compassionate response that is not SANE trained or certified actually look like? So when you say competent and compassionate, what does that actually mean for particularly the rural hospitals? Because I get that question all the time, and I always end up asking you for help.
Mm-hmm.
They don't have the program, they don't have the ability to sustain a SANE program. What does it mean to have a competent and compassionate response?
Yeah, I think, going back to the 8-hour medical forensic trainings that we do, rape myths and those kinds of things are so ingrained in our culture. So of course that's going to saturate professions like the medical profession. So that's part of our 8-hour training is really going through some facts and truths about sexual assault. I remember one time I was responding to a hospital in Minneapolis, and I had been there earlier in the week. So I had gone there on like a Monday, and now it was a Thursday, and I was coming back for a different patient. And the nurse in not the same nurse, but the nurse that was in the emergency department recognized me, and she said, hey, I want to give you the heads up, just so you know, the victim in there is a stripper. And I looked at her and I said, it's kind of interesting that you're saying that to me, because on Monday you didn't give me the heads up that it was a soccer mom. So really kind of dispelling some of those myths and letting people know the realities of sexual assault. I think, explaining to people 84 to 92% of the time the victim survivor knows their perpetrator. Because I think sometimes people have this stereotype that sexual assaults happen from strangers that are lurking in the bushes and those kinds of things. So really dispelling those kinds of issues, giving medical folks that background. And then, you know, basically, whenever you're getting a medical procedure done, whether it's for a sexual assault or not, nobody's going to feel very good if the medical professional is like reading a piece of paper and following directions, right? So we want to give people those basic skills so that they can perform that exam in a competent way. We want hospitals to be welcoming to victim survivors, and again, not turning them away. Here's something that I didn't bring up in this call, but in Minnesota, our sexual assault kit, it says on the outside, this kit will expire on such and such date. The only things that expire in the kit is a purple tube top on one of the tubes, and then a couple swabs. All of those things can be replaced from general stock in an emergency department, but you wouldn't know that unless you opened up the kit and got into the kit. So most people see the kit and see the expiration date and toss it. And I know Kansas, for example, has a really great kit. I like it a lot. It says on the outside of the kit, it just says, this expires on this date, but hold your horses. These are the only two things that expire. So that is an excuse, and I think it is an excuse that is used a lot, at least in Minnesota, where hospitals, oh, we got an expired kit, guess we can't do it. So that happens. Those, you know, so victim survivors are constantly being redirected to other hospitals, and that's one thing that I don't want to have happen, because that really puts barriers, and I think we all forget, including advocates, the courage that it takes to go to the hospital the first time, and then to be turned away. I think a lot of victim survivors say, forget it.
There's still a couple more questions.
Okay, when we're done with that question, I'll go over resources.
Judah's ready to keep going. Okay. Oh, there's another question that just came in. So 2 more questions.
That's awesome.
Any advice or thoughts around safety planning for when exam bills show up and have some of the information listed?
Yeah.
That they went and got a sexual assault exam done.
With the EOB, the explanation of benefits. Yeah, that is another issue that is really hard. Going back to billing, I've been very concerned about billing for that purpose, and I here in Minnesota, I think it's gotten a lot better. I'm going to knock on plastic because I'm very superstitious, but I haven't gotten a call from a victim about a bill, like getting billed directly, in a few months. I don't get those calls very often, and I've talked to a lot of different states about that, and in some states it's a big deal, and in other states it's not. In the state of Minnesota, victims should not be getting the bill because their insurance should not be being billed unless they give consent. And that's another direction, if I can go on a tirade here for a minute, that's another direction that is really concerning me, is that some communities are like, well, what if we just ask the victim if we can bill their insurance first? Again, we're talking about somebody who has experienced a trauma. I used to always tell victim survivors when I met them, hi, my name's Jude, and you're going to remember about 10% of what I'm about to tell you. So I think when people start throwing information at a victim survivor and, hey, sign this consent and sign this, sometimes I get concerned that victim survivors don't know what they're signing. But going back to the bills, there are some things, and this can be, it's not even county by county, this can be hospital by hospital. So I'm thinking of one hospital that just picks up the tab for everything. Like they eat the cost of the prophylaxis, they do everything. I'm thinking about another hospital that nickel and dimes those patients for everything they've eaten. Hey, you were in an emergency department bed for 4 hours, we're going to charge you for that. We're going to charge you for anything outside of what we deem meets the definition of a sexual assault exam, which kind of goes back to the kit. That's why we want to define that in legislation. What is a kit and what constitutes that kit? So I think if you've got a victim survivor, and I see this a lot with minors, I would talk, in fact, I just answered this question last week for an advocate. What I would do is really talk to the hospital. SANE nurses a lot of times are responding to multiple hospitals. So it's really hard. If you're responding to more than 10 hospitals, it's hard to kind of keep straight which hospital is doing what. So bring in that hospital person, ask the triage nurse, hey, we really need to know about billing. And that's kind of your safety planning right there.
Thank you, Jude. Another question from the audience. During your many years of experience, have you seen any shift in the occurrence of victim survivors with disabilities reporting? If so, what has been the shift and what do you attribute the reasons for it?
Well, I know, that's a complicated question because, okay, and you did say increase in reporting.
Yeah.
And I think that's what it is. I've been having a lot of conversations with people locally because we've had a lot of cases that have been in the media. People have been very upset about folks, particularly with intellectual and developmental disabilities and sexual assault. I do think reporting is going up because I think that there's been more awareness. I think in some communities it's become a health priority. I hate to say this, but I think some institutions have been shamed publicly and by the community, and communities have said this is absolutely unacceptable. So I think institutions are paying more attention to it. So yes, I do think reporting is going up. I don't necessarily think sexual assault in communities with folks with disabilities is going up, but I think reporting is.
And then I have one last question, if that's okay.
Absolutely, John-Anna.
We got someone coming back around and just trying to make sure that their question, just kidding, we'll hold mine. Just checking, is the question in regards to DNA and the forensic portion of the sex admissible without parental consent? So if they are a minor,
yes,
is that permissible?
Check with your local community. I mean, check with your state law. In Minnesota, yes.
Excellent. Thanks, Jude.
Sure.
So my last question to wrap this up as we are coming here to the end is, what is one practice around medical forensic response in rural communities that you are excited about to watch how it develops?
Oh, that's a really good question.
I know you talked to me about all these really cool things that are happening and things you've seen at conferences, so I would love for folks to be able to hear some of what you're seeing.
You know what? I'm really excited about telemedicine. That's something that I get really excited about, and SANE. I get really excited about, I've been able to recently actually see how the equipment works in rural hospitals. And that's something that I really want to explore. I would love, love, love to bring it to Minnesota. I'm really excited about the trainings that we are doing, both the 40-hour SANE trainings that we're doing and the 8-hour medical forensic trainings. I get really, really excited when people are engaged and they want to respond to sexual assault. Yeah, I think those are probably two really energizing things for me right now.
Awesome. Those are things that all of you listening to this either live presentation or the recorded version of this presentation can absolutely connect with Jude to hear more about, because Jude actually likes talking about these things, which is amazing.
Thank you for saying that. I'll give you that in a second, my contact information, but here's some other resources. Right now we're in the process of updating our website. Don't worry, it's not down or anything, but we do have a medical forensic compliance section on our website, so you can check that out. Also, our friends at Violence Against Women International have some great stuff around medical forensic compliance. Again, check out the National Institute of Justice with their study about best practices around kits. That was a fascinating read. The International Association of Forensic Nurses obviously has a lot of stuff on medical forensic compliance. And our friends at the National Sexual Violence Resource Center also has some great things around medical forensic compliance. We already did this, right? Are there more questions?
Yes, there are currently not any other questions.
Okay. Well then, folks, seriously, I love talking to other states about things. Even I have called, well, there's probably people on this call that I've talked to because I just love brainstorming about things. I love learning about what's happening in other states. I like getting guidance from other states. But if you have questions, if there's anything that I can ever do to help you, please don't hesitate to shoot me an email or give me a call because I love talking about medical forensic compliance.
Yay, thanks. So big thank you to Jude for taking time out of her actually very busy schedule to take time and do this webinar with us for the rural program, and for all of you who have participated. You're getting a whole bunch of thank yous here on the chat. I'm going to pull it up so you can actually see all your thanks. As a reminder to everyone out there, you can absolutely sign up for our listserv. If you go ahead, please email me at jgans@mincasa.org. Send me your name and your email, and we can sign you up if you're not currently on our mailing list. And if you're on our mailing list, you'll just keep getting the occasional emails about the cool stuff we're doing and opportunities such as this webinar. Our next webinar for the rural program and in this series will be on sexually exploited youth and working on sexually exploited youth trafficking coordination in sexual assault response teams and communities that are working toward that. That will be happening in September. You can also get a hold of us through the Rural Realities blog, which is a weekly blog I keep about doing SART work. Jude might just be a guest featured writer one of these days. Yep, Jude, this is my actual invite for you.
Oh, wow. Okay, I'd love to.
So thank you everyone for joining us here over the noon lunch hour in Central Standard Time, and thank you so much to Jude for sharing your knowledge and experience. Please reach out to us if ever you need anything, have further questions, or you just want to get real nerdy about sexual violence response of any kind in communities, because we're all about that.
Yeah, thank you for listening.
Everyone have a great rest of your day.